All right. Well, I guess we'll get started. We can first of all, thank you for coming today. Happy Doctor's Day. Today is Doctor's Day. So for all the doctors out there, happy Doctor's Day. But I want to say most importantly, and if we can we show the screen? There we go. And this is our star list of lineup speakers, Dr. Yurikov, Burks, and Basil, who will work remotely, and Dr. Kumuk, talking about various aspects of spine and peripheral nerves. But most importantly, I want to thank all of our industry partners for coming today. And we have a healthy list, and I just want to call them out individually. Biogenics, Depew Synthes, Eloquence, Globus Medical, Integra, Medtronic, Nuvasive, Republic Spine, Sonara MedTech, Spinology, SpineX, Stryker, TrackX, Vivex, ZimV, and that's it. So again, thank you again for helping sponsoring this spine symposium that I think we're like in our 4th or 5th year, and we have a cranial spine symposium at the end of the month. And we're looking forward to that. So my talk is going to be on motion preservation, and we'll get into what that means exactly. But it's really going to be focused on artificial disc technology and laminoplasty. Here's my non-relevant disclosures. And so what is motion preservation? And it's kind of two opposing themes: motion preservation versus a procedure that starts with FU, but is only it's 5 letters instead of 4 letters. Fusion. You were thinking of something else, but no, I was going to say fusion. So it's really this diametric fight between motion versus fusion. And the patients ask about this. If you start talking fusion in the clinic, I would say most patients want to know, is there any other options? And I can tell you it's not for everybody, but there are some patients who are good candidates, and we're going to go over that. And we're also going to go over patients who are bad candidates. And I think one of the important concepts is that motion preservation doesn't equal motion restoration. And so what that means is, unfortunately, I will see a lot of people who have artificial discs placed, like that patient to the right of the screen, who literally have a fused disc space. Those are not the right patients for an artificial disc. You can't take a fused disc and restore motion. And if you try to, one or two things will happen. They'll go on and fuse anyways, or you can potentially have complications. But the thing that drives me the most crazy is that it breeds a subset of surgeons who are, I will call them the disc haters. So these are the surgeons who don't do any artificial discs and say, I've taken out 10 this year. I've never put one in. I've only taken them out. And I would bet that, most of those people who end up having those discs taken out are people who are not the right candidate. So I think it's really important to pick the right patient, and it's a relatively small subset. I would tell you, for every anterior cervical procedure that I do, probably 1 is a candidate for an artificial disc. So 1 out of 15 are actually candidates. And I would say I'm on the side of being extremely cautious about who I pick. I mean, they have to, we'll go over the indications, but why did this even ever come about as a concept? And it's definitely not a new concept. It's been around for now 35 years. And the earliest versions of artificial discs were actually made and used in England in the early 90s. And this guy, Brian Cummins and Steve Gill, literally developed the technology in their garage, made the disc and started implanting them in Britain. And that was the very earliest version of the Prestige disc. And it basically went through iterations. We actually were one of the first, I was telling the residents, one of the first people to implant an artificial disc as part of an FDA trial back in 2001. And so now we're in 2023. That's 22 years ago. And so people look, oh, wow, this is like artificial discs. They're new. I don't want to try anything new. It's not proven. There's really, it's been around for a long time. And I would tell you that there is more data out there that's prospective, randomized in artificial disc technology than there is in anything that we do in spine. It's probably been the most investigated. And the question is like, why even think about doing it? Fusion works great. Why would we want to do anything else but fuse? And there is this concept of adjacent level disease, and there's definitely different definitions of what adjacent level disease is. You can have radiographic adjacent level disease, or you can have symptomatic adjacent level disease. This is an example of radiographic adjacent level disease. And this is a great paper that I love to quote from Dan Rue, which basically tells you that if you're doing an anterior plate, it's really good to make sure the plate is as far away from that next disc space, because if it is too close to the next disc space, you enhance the rate of adjacent level disease. But that's just radiographic. And is it important? It probably is a breeder of symptomatic adjacent level disease. The most quoted and often misquoted paper on adjacent level disease is from Alan Hillebrand and Henry Bowman, and that was data that was done 20 years, 30 years ago, between 1973 and 1992. It was even pre-MRI era, but it was all of Henry Bowman's patients. And it was a mixed bag of people who've had single and multi-level fusions. But why it's such a good study is that it has a pretty good long-term follow-up, and you need long-term follow-up to know or understand what adjacent level disease is. And at that time, nobody left Cleveland, so he had a good follow-up. Now everybody's leaving Cleveland and coming to Miami. And this is basically what they found out is that when he looked at his patient population and saw who presented with symptomatic adjacent level disease, that the incidence was 2.9% per year or about 25% in 10 years. That's like super high. I mean, if you're proposing an operation to a patient and saying, well, we're going to do this, you're going to do great, but there's at least a 25% chance you're going to be back in 10 years for something else. That's not very appetizing, I think, for the surgeon or the patient. And so that's really how this concept of why don't we continue to keep motion, and that was the basis for this study that we were a part of back, that started in 2002. I think we recruited like 20 patients. I think Kathy Rosenberg was involved, but I know Shelley Garcia was very involved as our nurse clinician for the study. Dr. Vanny submitted patients to it, right? I think you were the only one. I think it was just me and you. Yeah, who submitted patients to that study. And I see these patients, like literally I've seen a patient that we did 20 years ago. She was a mother and now she's a grandmother. just to give you an idea of, and I personally, of the 16, 17 patients that I implanted, I've never removed or revised a disc from that original study. What we did is we published a paper a few years ago, won the CNS award for best paper of the year, but it was basically looking at the 10-year outcome data of this study. With the 1 year, the 2 year, the 5 year, the 7 year were published, but then we had up to 10 years looking at NDI success rates and neurological success at 10 years and preservation of motion, looked at arm pain scores. But I think that, the one thing that I like to show is that for this study at 10 years in the 50% people who had follow-up, that the disc was still moving. When we combined both the Bryan and the Prestige, we saw a statistically significant reduction in adjacent level disease at 10 years. So we had to look out 10 years. You don't see it at 2 years. You had to look at 10 years, and we had to pool the two study populations to get enough patients to see if they were statistically significant. The other interesting thing that we saw was that this 2.9% per year adjacent level disease rate in the fusion group was a lot lower in this study. So that 2.9% is probably a little bit higher. It was instead of being 25%, it was more like 17, 18% at 10 years. So a little less than what that original study quoted. What were the strengths and the weaknesses? You can see here of what that study was. The point I wanted to make here is that it's 2.9% per year in the paper, but not everybody went to surgery. So if you look at significant adjacent level disease requiring surgery, the Hillebrand's paper said it was 2.2%, and our paper said it was more like 1.6%. So a little bit less than what was out there in the literature. And the discs did well compared to fusion with respect to pain, motion, neurological success, etc. This is just an example of a patient that we had done 12 years ago that I literally just saw in the clinic. And you can see here that he is still moving 12 years post. How can you tell he's moving? You can see a lucency here, and then when he flexes, it clamps down, and you can see some widening of the inner spinous space. And the problem is that the imaging is not great on him, and he actually was coming in for further degenerative disease, but not adjacent to his prior artificial disc, but 2 levels above. But the point of the paper or this picture is that there's a lot of artifact. I mean, you can barely see anything, certainly at that site of where the surgery was done. So there are new players in the market, and I can't go over every single artificial disc. I'm just showing you one of the ones that we have been tended to use here, which is the Simplify that has both lordotic and non-lordotic options, 3 different implant sizes. This is what it shows post-op. It's proved for a single and dual level. And these are what it's made out of, sort of peak end plates and zirconia toughened alumina ceramic core, and it has minimal wear debris, and it is nickel free. And this is some of the results of their 1 level and 2 level IDE studies. So that was all I was going to say about artificial disc. I was just going to talk a little bit about the other potential motion sparing operation that's done posteriorly, which is cervical laminoplasty. I mean, laminoplasty has a rich history here that is dates back to the 70s. Again, from a historical perspective, when it was Dr. Eisman and Dr. Green, they had a visiting professor from Japan, and I can't remember exactly who it was, but who showed them how to do laminoplasty. And I think this center, you know, in the 70s and 80s was doing laminoplasties. And so it's been around for a long time. The most common variety of laminoplasty is the open door variety. There's about 10 different techniques, but open door basically means that you drill a trough through and through on one side, you have a hinge side on the other side, and you open the door to give more room in the spinal canal. And traditionally, you know, we've always used rib allografts, which we had to cut and put troughs in. And it was technically challenging because you had to open the lamina in a way where there was still a force closing down on the ribs. And if you kind of broke the lamina and it was sitting there floating, then putting those little ribs, they would fall out. And we certainly had the occasional case that a rib would fall out. And you can imagine if it does fall, that's a big problem because it's going to fall into the spinal canal and contact the dura. So, from that, there have been advances in mini plates to hold the lamina upwards, so you can feel less worried that would happen. And in fact, when we did the ribs, I would have everybody in collars for 12 weeks. But now with the mini plates, we don't use collars. We just use, soft collars. And this is from a publication from 2008 that, Manzano was the first author. And then the rest of the spine surgeons were contributors. And I'm just taking one image from that paper, which basically shows that at a year, and all of these patients had 1 year follow-up x-rays, including flexion extension views. And if you look at the range of motion from C2 to C7, both pre-op compared to 3 months post-op, compared to 1 year, if you compare these two bars, you only had a 30% reduction in range of motion at 1 year. I was going to ask Dr. Arya, how come you think that it went like from this to this at 3 months, and then it got better from 3 months to 1 year? It's a tough question, but I know you're a real smart guy, so you'll figure it out. Why did it get reduced and then it got better at 1 year? So smart, that guy. Yes, they were in a collar. So that was like the negative effects of the collar. Like the collar, basically, you took them out of the collar in the clinic, and they were moving their neck for the first time, so they were very like trepidatious. And so that's why. And then at 1 year, when we saw them, they were then 12 months post surgery, and they went back to their baseline range of motion. Now, how about the laminectomy and fusion group? So that was their movement before surgery, that was their movement at 3 months, and that was their movement at 1 year. So you can see that when you're fused, you're fused. You don't move anymore at 12 months, which makes sense, right? That's what you're trying to achieve, is rigid fusion. And this was one of the really premier articles back in the early 2000s by Cooper and Hooten. Dr. Cooper was a surgeon at NYU, and him and Dr. Green used to do this at meetings. Green would talk about laminoplasty, and Cooper said that that's baloney, that you need to fuse the spine to fix people. And so they would have literally screaming matches at the joint section, which it was extremely entertaining. But this paper, you can see here that this patient had severe stenosis, well decompressed, intrinsic cord changes. But if you look at this level here, he's already started to develop adjacent level disease below his fusion. And this is the paper in neurosurgery. And these are the old plates and screws that they used to use to do the fusion. And we sort of observed a similar thing where people, if you do especially a short segment fusion, they can start developing adjacent level disease, at least radiographically, within a year. This is a patient who is in our study who, if you look at the 6-7 level, compared this to this, he already started to develop spinal stenosis at the level below his fusion. And if you look at laminoplasty adjacent level disease is like super rare, like incredibly rare, so rare that when we saw a case, we published it as a case report in neurosurgery. This is someone who had a laminoplasty post-op, and then came in 3 years later and developed adjacent level disease at like T2, T3. And this patient had Parkinson's. God knows what was the contributing factor, but he ended up needing a revision. There's been a little bit more excitement on the laminoplasty front recently. I think it's a hard sell for some surgeons. I think part of it is CPT related. But there has been more excitement lately. This was a paper in JAMA. And the first author is Zohar Gogawala, and basically looking at these 3 different procedures and the outcomes. And certainly laminoplasty was effective and had a very, very low complication profile. Who are great candidates, and like I said, it's not everybody. There is a subset that are good candidates. This is a young guy. He's a polo player. He had an MRI for neck pain some 11 years previously. You can see he had minimal stenosis, certainly no role for surgery at that time. And then he came back 11 years later with myelopathy, never had really an accident, which hard to believe in polo, that he hadn't fallen off his horse at some point in time. But he came in with myelopathy. You see he has severe stenosis at this point. He has intrinsic changes at multiple levels. He has a well-maintained cervical lordosis that was confirmed by x-rays. You really have to see x-rays to confirm that they have a well-maintained cervical lordosis. And that is the post-op imaging, both x-rays and MRI. And the guy still is playing competitively post laminoplasty. We use it in central cord injury if there's no evidence of instability. And Dr. Uribe, back in the day when he was a fellow, he's now published like 700 papers. But if you look at his PubMed, this was one of his first papers that he ever published, and it was using laminoplasty for central cord injury. And from here, who are not good candidates: kyphotic patients, primary ventral cord compression, OPLL patients. I used to do them on OPLL patients, and I changed my practice. I pretty well do fusions only on OPLL because there's some literature in the Japanese literature that suggests that if you do a laminoplasty, they continue to form bone if they're still mobile. And if you do a fusion, that you halt the OPLL formation. And obviously for deformity, we don't do it. I think the laminoplasty technique is pretty straightforward, although it can be technically challenging depending on the patient population. Again, we talked about it. There's a hinge side, there's an open door side. You have to disconnect the ligamentum at the top and the bottom. We typically remove the spinous processes and we crack the door open. And then again, there's multiple things that you can use as spacers that usually fixate onto the lamina and the facet joint. We'll typically put autograft on the other side, not to fuse between levels, but to do an intersegmental fusion. These are some of the mini screws and stuff that we can use to fixate the lamina and the facet. I'm just going to finish off by a paper done by Brusco, Levy, Jr., and Wang. And it was basically a prospective assessment of C5 palsy. And I say prospective because it's from a database that looks prospectively at complications, and seeing, is there a correlation between C5 palsy and the side that you put the open door on? So is C5 palsy more common on the open door side, or is it more common on the closed door side? What would you think, Dr. Theodotou? C5 palsy, more common on the open door side or closed door side, without looking at the slides? And why? Right. So it is more common on the open doors. So that was the hypothesis. So we looked at 327 cases, 272 were included. There were certain that were excluded if they had a pre-existing C5 palsy or were a severe spinal cord injury, or if they were instrumented. So of the 272 cases, 96 were done on the right, 176 were done on the left, and there were 7 cases of C5 palsy for an incidence of 2.6%. You can see there are all types of severities, mild, moderate, and severe. But the point was that 6 of the 7 cases happened on the open door side. And there's a lot on the literature about prophylactic foraminotomies. Some here did, some here didn't. I would say that there was a negative tendency for foraminotomy as opposed to a positive. The Japanese talk about doing a prophylactic C5 foraminotomy to reduce that incidence. I would tell you the incidence was pretty small, 2.6%. 3 to 8% in the literature. And the other thing I would tell you is that it happened more on the open door side. And why is that important? And it probably relates to this video, is that when you're lifting the open door, there's probably more traction of the nerve roots on that side. You certainly get more decompression on the side of the open door when you looked at a post-op MRI. But you have a choice. If someone has circumferential stenosis and they are a candidate for either a right open door or left open door, what side would you do it on, Dr. Vasiri? They're non-dominant. And so, because if you, and this is from personal experience. So I broke my shoulder 6 years ago into 3 pieces skiing. And, fortunately it was on my left side. So if you have, if you're right-handed and you can't move your deltoid, you're still pretty functional, right? But if you break your right shoulder and your right hand dominant, it's not so easy, right? So given that you have a choice, it's better to do it on the non-dominant side. So I always ask my patients, are you right-handed, left-handed, and try to make, now it's not that common anyways, and most of the cases tend to be mild and moderate and recover, but you can imagine the patient is upset if they have any neurological deficit, and it isn't necessarily anything that you've done wrong, but if their neurological deficit is on the non-dominant side, so much the better. And then my last slide on fusion versus motion preservation, which I love to ask surgeons at meetings, if you had cervical stenosis, and we might develop it, would you rather have a laminoplasty, Dr. Burks, or would you rather have this operation here? It's very cool. Look at all the screws, go down to C2, T1. What would you rather have? Yes. Laminoplasty. There you go. So that's it. That's all I got. I'm happy to answer any questions. Done. New data from which study, or just in general? Yeah, I think the outcomes are good, excellent, 1 versus 2 level in the right patient. And only certain discs, I believe, are FDA approved not FDA approved, I should say insurance approved. There's a lot that are FDA approved, but only a subset that are insurance approved for 2 levels. Professor Vanny?
Do you think there's any data or change in the data between axial loading, unloading type of disc versus discs that allow for motion but gliding? And not true, the difference between the Bryant disc and the other disc that you showed, like the Prestige disc.
Yeah.
The difference in that particular implant,
Mm-hmm.
which was more difficult to implant,
Mm-hmm.
but it allowed for loading and unloading, where these other discs allow for motion, but no true axial loading and unloading. I don't know if that matters in terms of adjacent leveling.
I don't think anybody knows for sure. I don't think that's been, yeah, but that's, I was a big fan of that technology because of that aspect, and that, some of the discs only allow even sliding in one plane, some in multiple, but this was multiple, and it would allow for some compression. At the end of the day, it was taken off the market, not because of issues regarding the disc or harvesting, but it had to do with the supply of the tissue of the elements, some of which came from China, that were used to make the disc. So it's been off market for, I want to say, like 4 or 5 years. So I don't have an answer for that question, and there really isn't anything out there that is similar. Most of them are sort of ball socket type of things with a keel. Dr. Vasiri.
This is one of the places that does the most laminoplasties. Just out of curiosity, because you guys put the bone on the contralateral side.
Yeah.
Have you guys looked at your autofusion rates?
Yeah, so we put it specifically intersegmental. We don't decorticate the facet joints. So all we're trying to do is make sure that lamina that's elevated actually fuses in that elevated position. Now, if the question is how many undergo spontaneous fusion of the entire spine, I think it's very rare, because it would have manifested itself in those flexion extension views. So there's a 30% loss of motion. Is that because maybe one level ended up fusing, or is it just because you've altered the biomechanics of the entire spine? But they definitely do not fuse from C2 to T1. If you put a little, and I try to put just like a little drop of bone at 3, 5, and 7. Cool. So with that, we're going to have our next speaker come up, Dr. Yurikov, who needs no introduction. And we'll switch over the slides. So I'll just disconnect here. Cool. Thank you. Whoops, and let me grab my phone.
All right. Thank you, Dr. Levy. Good morning, everyone. Good to see you all. Thanks for the industry support. Tremendous show of force today. Let's switch gears a little bit. Love how Dr. Levy's talks are always data rich, supporting his every notion and idea. You can't even argue with that. You can argue a lot with any of my slides today, you'll see. So here's my short list of disclosures. Come on, guys. Gotta keep them up, right? So we've had the robot now for over a year. We've been using Globus Excelsius at Jackson. And of course, there's a learning curve involved, but I think we're a little bit over that already. And now we're starting to get more and more comfortable and kind of exploring different variabilities to how we use it regularly. See one of the reps, John here, how gray hair he is. That's from trying all the different things that he's not too comfortable with. So in terms of pedicle screw placement, by now we know the robot works, right? Here's a trauma case that's pretty obvious. And it was done by Evan Luther, I think, in Sumed. You two just instrument that. Look how well it was done, how well the screws match, and pretty much what you see on the right image with the axial, every single level is like this. So there's a good reproducibility to this. And this was done with me just supervising, right? It did not require me to hold their hands. This was all done using the robotic system. allowing us pre-plan the screws, get the right setup, and execute it well. So we know it works for the pedicle screws. We've also done it now a lot in the single stage lateral cases. And I don't know if these videos will play. Here's Cadbury instrumenting, placing a pedicle screw while I do my exposure on the other side for the oblique approaches. And that, I think, helped me with the workflow of these single stage lateral procedures. Most of you have been in those cases. You saw for yourself. There's still a lot of troubleshooting, and a lot of times you kind of have to be very involved. It's very work heavy surgery overall. But when it goes well, it goes very well. And it's amazing to see those patients get up the next morning and just thinking, saying I thought I'd be in a lot more pain, and they're a lot more mobile than they, the usual surgeries that we used to see was big open traditional exposures and big blood loss, long surgeries, drains. So we know this works in lateral too. So pedicle screws, you get a big check mark for the robot. That's what it's been designed for, and it does a good job at it. Just some other videos just demonstrating how Cadbury just totally dominates it. And this one I like, just watching this thing move is always cool, and even though it's slow, but it's kind of a nice little break in between. And for this particular case, you can see all the x-rays that were taken. Those 5 shots, all that was required to register the robot. This was one of those times when we used the x-ray to get the 3D scan registered. And it's amazing. So you're not wearing lead for the most part. You see me wearing it more for the interbody stage of it. But that's not what this talk is about. What else can we use the robots for? And here, very happy with Globus how they were accommodating, and they were just allowing us to make these custom parts that would connect different retractor systems and allow the robotic arm to hold on to this retractor, which is, I think I've shown you this slide before. I've tried every single retractor that's out there, and pretty much I know all their physical properties and flaws and benefits. Having the robotic arm that's super sturdy and doesn't move, holding your retractor is just a game changer. All right, let's talk about some of the cases that kind of maybe a little bit less traditional for what the robot is used. Here you can see a patient that fell backwards, had a odontoid fracture, pretty well aligned and overall favorable anatomy. So we've elected to use the robotic system to help us with this. Positioning is important. You have to keep in mind that since the O-arm, at least in our case, O-arm is being used to get the 3D spin, you have to get the Mayfields and the tables so well oriented so nothing gets in the way and there's no collision. So here we're using the double arm carbon fiber frame that's not going to get into the X-ray views, and it's not going to create any artifact. And at the same time, it allows for that lower, flatter mobility because of the double jointed construction. And I'm going to talk about chest line in a second, but that's one of the big considerations. Whenever you do an odontoid screw, we have to keep that in mind. But if you use something as bulky as a robotic arm, there's even more adjustment that has to be made. So this is the picture of how the 3D spin we were able to perform it. Having done the exposure ahead and placing that retractor in place so you can see your preliminary projection point is the key. You don't want to make any more further major adjustments after 3D scan is done, because we had tried that and we had failed on the later cases. Because once you start retracting, things move, cervical spine is pretty mobile, and if you have a fracture in it, it's even more so. And then here's that picture for the chest line considerations. You can see the arm of the robot has its own volume, its own footprint. So you can imagine that you have to have an extra inch of what you would normally have for the traditional odontoid screws. And here's just part of the steps. And Greg Basil did this case, and I think he's the only one that's done it. I wasn't able to replicate it later in another case, had to abort it just because we couldn't get the navigation going. And the outcomes, right? So we had the software plans for pedicle screws only. So now you're putting a pedicle screw on the software and you're designing for a pedicle screw to go into the C2 vertebral body, traverse the fracture site, and go into the fractured dents. So that's what it looks like on the left screen with the, and you can see the pedicle screw with the tube. Obviously, you're not going to put the screw itself. You just need that trajectory. And all robot is a tube, right? It's a tube that gives you a line in space And hopefully that line is correlating well with the 3D images and the actual patient. And you can see on the right screen, the post instrumentation O-arm, how the plan pretty much correlated with execution. And that's the power of the system, right? When all the preliminary steps are done right and everything works, it's going to give you good outcomes. But now you have to think about more of these preliminary steps and not screw them up. Really take care of all the setups. Don't skip steps. Don't cut corners. And that's how you get good outcomes for these. So this was one of those lucky cases where we got the screw where we want it to be. I have a 6 months follow-up on this gentleman right now. At best, I can say it hasn't failed yet, right? It's I can't tell you that it fused or not, but at least there's no lucency around the screw. There's no evidence of any extra motion. And if you start kind of really zooming in onto the fracture site, maybe you start seeing some bridging bone, which is optimistic and hopeful, but at least clinically he's doing well so far. All right, switch gears again. So this case is of a gentleman with a spinal cord injury, and we see a lot of them. It's a common kind of sequelae of someone who's paralyzed and sitting in a wheelchair to develop this Charcot joint, which is a highly inflammatory situation around the spinal cord and the vertebral bodies. For this particular gentleman, when he first came presented, he had autonomic symptoms where in certain positions of his torso, he would create blood pressure spikes to 200s. It was very reproducible. We could sit him in the wheelchair, and just by tilting back and letting his spine kind of compress by extending backwards, the blood pressure would skyrocket. At first, I didn't believe this was instability. So we did a laminectomy, decompressed him. I saw the spinal cord, everything was well decompressed, and he did well for a little bit, but then the symptoms started to happen again. And at that point, I already said, okay, it's obviously we got to fuse it. It keeps happening. And it was interesting when I went back in there, because I haven't done any reoperation on the Charcot joint, I got to appreciate how inflammatory this condition is. When we reopened, the site of laminectomy was filled with this cartilaginous, soft but cartilaginous material. Dr. Vanny, you've seen that before? Just like as if, there was really a lot of inflammation that happened. It scarred in, and that was creating new pressure. Even though laminectomy and decompression had been done months prior, he just regrew. It's very interesting. So for that case, of course, that was a second surgery, and we already planned now for instrumentation. How we did it. So the usual pedicle screws, yes, it's nothing new about that. But now getting to that disc space, he's large, has comorbidities, and doing a transpedicular approach to get all that stuff out or to create a fusion mass anteriorly, I wanted to reduce the risk of in the bearing of the surgery on him. With the robotic system, we use a navigation platform to allow us to plan this trajectory that you can see on the left screen with this oblique screw that kind of looks like that. Again, that's not the screw that replaced, but we have to use that software to plan it to go into that direction. And that almost allowed us to go extrapedicular, slightly transpedicular, under the rib, into the disc space. And you can see on the bottom left of the four-pane picture, how the tip of that screw is in the disc space. So that was a plan. That's how I gained access to that disc, and we were able to execute it. You can see how on the left picture, using the robotic arm, put us in that trajectory. Exposure, as usual, you don't have to do any extra exposure, but now having confidence in navigation, I know that trajectory will go through a safe place into the disc space. It's a quick step of just using a sequential drilling, gaining access to that space, trying to decorticate as much as possible. And then this is the funnel that goes in with the biologic graft to hopefully promote some fusion across the disc space without any added morbidity of the surgery on the patient. And afterwards, he did well. And so here's the next case. Usually we see this picture of isthmic spondylolisthesis in young patients. There's variability of anatomy. There's a lot of times traditional levels, and the pars fragments of the lowest lumbar segment is underdeveloped or weak, and it fractures often in young athletes that are otherwise very fit and athletic. And here they have to deal with this high-grade slipping situation with a high sacral slope. Trying to do a T-lift on this, you'll see all your instruments going to be parallel to the floor. You can see the orientation of the sacral end plate. So traditionally, we would do either Bowman or indirect Bowman go through the front, and that's how I've been trained, and I've done those cases, and they do wonderfully. This is one of the medical students that I did earlier, about 3 years ago. At 1 year, everyone does well, right? Once you've done that, gone over that whole post-operative pain and recovery, and you've stabilized their segment, they do great. There's no more pull in the L5 or S1 neuro root. Their legs feel great, their back feels strong, and they're back to being normal. So, but of course, this surgery is quite involved too. You can see there was an anterior component and stage 2. Patients in the hospital for over a week, a lot of pain, drains. And I think in this particular case, even this was a young gentleman, he came back and he was wondering why his ejaculation is not the same. So it's a real risk as well, right, with young people of having retrograde ejaculation, which has been described, but how can we make it better? Can we just say, yeah, it's part of it, you just live with it? Or is there something that we can do? So here's a different way that the robotic system allowed me to think about this and try it out. And now we have 2 cases like this, and so far, with the 6 months follow-up, we're doing okay. Still not out of the woods yet. A lot of things can still go wrong, but at least it's going well. So let me take you through this. Same condition that I showed you before. So the x-rays look all about the same. High degree slip, symptomatic, needs to be taken care of. Here's the surgery, all done in prone position percutaneously. So now, and we're dealing with the lumbosacral junction, which has very little mobility. It's not like that highly displaced fracture I showed you earlier in the thoracic spine, where 2 segments move a lot. So here, everything's solid. The percutaneous pin is placed. You can see it on the scout image right here, and that's your navigation line. There's some considerations there because a lot of the trajectories, look how they fan out. Look at the purple lines, they fan out from the spine. If you don't put that pin and the navigation array in the proper position, you'll be fighting it, most likely. The planning allows me, since we're doing percutaneously and the angles are all highly off the usual trajectories, the planning allows me to just have the tulips in the straight line. But that you have to keep in mind, for these screws that are highly oblique, there's a limit to what the tulip can accommodate, and it just has to be kind of considered when you do this planning, because if the tulip cannot bend in line with the rod, you won't get good grab, and the set screw will not final tighten well. And here are just some of the pictures how between the navigation setup after the O-arm spin and the robotic arm. This is a position of the arm in the middle screen for the first, that top level that's being that's slipping forward, right? You can call it L5, S1, depending how you count, but let's call it L5. The listist L5. You can see how far out the trajectory reaches, and that's the necessary evil, because usually those anatomic variations to those levels create almost like a sacral orientation of the pedicle screws, but on the mobile segment. And those screws are very medialized. Imagine trying to get that trajectory in the open case, getting the midline incision and trying to retract that tissue. You'd have to have probably 10 inches of just midline incision to be able to pull that muscle and tissue away. Here, percutaneously, the robot places it right here. We trust it, and we go ahead with it. On this picture on the right, that shows how, and I'll later show you the screw that goes across the disc space that's being compromised in a similar fashion that I showed you in the Charcot joint case, using sequential drilling and then placing funnel pre-filled with fusion biologics, and that gets funneled into the disc space to help promote the fusion across that area. When you go level by level, this is how the screws look. And you can see how medialized. This is the top level. This is that L5 segment. Look how medialized those screws are. In the open setting, something would get compromised. Either you would go through the facet joint, the screw would be very vertical, you'd be breaching outward. In the percutaneous, having that freedom of being in any plane allows you to actually just be in the bone and preserve the 4-5 capsule. This is the interesting screw, right? Transdiscal tricortical screw. And Greg and I looked at it in Biedermann lab, the strength of the screw, how much better it holds on. Now you're traversing not 1, not 2, but 3 cortical surfaces. And orientation of the anatomy, just because of that high slip, high sacral slope, this screw becomes pretty vertical to the floor. You're not fighting the angles at all. You can see the way the arm is oriented. This is the trajectory of that screw. Of course, you can see it's pretty long. I think it's about 60 or 65 millimeters. And the intermittent step before the screw goes in, that same disc space gets filled in with the fusion graft. And the last screw, just because 3 points of fixation, they're always better, creating a good solid line. With the starting point a little bit lower around the S2 area, but using the alar as your fixation. And this feels like a very solid screw as well. When it goes in, it has that high distinguished creak sound that you know that screw is not going anywhere. Adding to the stability of overall construct, because you're dealing with highly unstable spine, and now the fixation needs to correlate. So that screw goes in more from the medial to lateral trajectory. You can see on the right screen how the robot orients it, and now it's more of a midline incision. And both screws go through the same incision. That incision is about 2 inches, and it's also what's used to gain access, and that's what I used to remove any of those mobile fragments that were in the foramen, any of the broken parts, to do the decompression, as well as reach on the lateral side and place some graft for fusion there too. So now you have a 2-inch midline incision that can accommodate all of that instead of a 1-foot incision that we'd normally do to get the screws and place the graft. So those are the 3 screws, and kind of you have the plan. And the post-operative execution. Again, the robotic system allows you to be pretty precise with what you plan and what you get. There's no, unless you screw something up and bump the array, there will be no deviation from that. Okay. Yeah, so that was in that case. So you can see, talked about prone pedicle screws. Yeah, we do it. Lateral pedicle screws, we do it. Odontoid screws, I put high caution on it. It's cool, it's fun, but most likely will not work. So, it just requires more still investigation. Transpedicular, extrapedicular access to the disc space that I showed you with the Charcot joint. I put help wanted because we had to modify a lot of things. The funnel itself needs to be navigatable. It's going to be, there's still some work that needs to be done to optimize the procedure. And still with this new way of fixing the high-grade spondylolisthesis, of course, further follow-up at 6 months. Amazing how both patients, same schedule. They were 2 nights in the hospital, first night, and then we watched them over the day. They were doing well, and then after they both left. At 3 months follow-up, doing great. Now we have just 6 months text messaging back and forth, and they're all very happy. So compared to what I had with the gentleman that did Bowman, reverse Bowman procedure, it was a very painful recovery, a lot of different considerations and big incisions, a lot of healing. It seems like that early phase of healing is already more beneficial with the MIS technique. All right, that's it for me. Questions?
So for the last case, you mentioned putting bone graft at L5S1, I assume. Are you using the same tube, or what are you using to get? Are you going to Cameron's triangle to put in bone graft in this case, or do you just rely on your S2 AI screws and transversal?
In preparation for that passage for the screw, the channel is made, and that's the channel that traverses the disc space. So that's where that funnel goes, just the same place where the screw would go, only the funnel ends at the disc space, and you put the graft into the disc that way. And that's a good question, because that's the other thing, from the TLIF era, we're always think about how much of a disc we have to prepare. We have to remove a lot to create a good volume, because in these MIS, with the current limitations, there's not much of that happening, right? You just hope that by putting that graft in there, something will grab, and we'll see if it does.
How do you accommodate if you're doing a correction of their deformity intraoperatively? So if you had a high-grade slip, you're putting in your screws, how do you do another intraoperative spin? How did that workflow occur?
It's a good question, and I think that's a different discussion. Should we be accommodating for that correction? If I just fuse them in a good orientation, creating a good kind of top level slope for the rest of the levels, is that enough? And if I start correcting it, will I be pulling too much pressure on the nerve that's kind of used to being that orientation? So I don't make that as a goal, at least so far. in trying to bring them back and make them X-ray perfect.
Have you looked at how much radiation risk you're you're protecting yourself compared to like the older surgeons who get x-rays every 10 seconds?
Well, you measure it by how much hair they have on their head.
No, I mean, there's a lot to say about the x-rays.
There's just no radiation, right now, this whole time, there's no X-ray, so. All right, thank you, guys.
Good morning. So Ignacio, thank you. I see a thumbs up. And then I see a pause sign. Nice. Okay, so we're gonna change gears and talk about cell therapies and nerve repair. I too like doing spine surgery, and there's a large breadth of cases that we have in spine, so we're fortunate for that. But we're going to talk about a laboratory investigation that we're doing in the nerve lab, and I'll talk about who our key players are at the end, and I'll give them a thanks. We have some support from Integra, by the way. So there's several challenges in nerve repair, and one of them is having to take nerve out of someone's leg and suture it back in. So you have nerve allograft, and then you have conduits, and these also known as axon guidance channels, that's kind of a cooler name, or ACGs, and they provide the ability to introduce other things like cells or cell particles, which we'll talk about later. And I think Schwann cells are a natural choice for cell supplementation. They'd be the perfect choice, essentially. And what we would really be looking to do is create an off-the-shelf product that you could just maybe even take off a shelf in room temperature or in a freezer and bring that into the case instead of making a big incision on the leg and pulling out the sural nerve. So this was investigated by Dr. Levy and their lab in 2013, looking at the supplementation of Schwann cells into just a hollow tube, looks like a straw made of collagen. And they showed that Schwann cells basically improved all the outcomes that they looked at. So in that time, Integra came out with the Neurogen 3D conduit. And you can kind of see this is from their brochure. It's a next generation conduit. It has this inner matrix that recapitulates or basically acts as the internal basal lamina, and it has all these little tracts that axons can grow down because axons are looking for structure to grow onto. So then that has been investigated by several labs and shown to be improved over the old hollow conduit. So then we sought to add cells to it, and we published this in 2021, showing that the addition of cells to these next generation conduits was powerful and that it was on par with autograft. And in rats, we have this sort of positive control of just reverse autograft. So our animal model, which I'll talk about, is we just cut out the sciatic nerve, and then in the positive controls, we just flip it around. There's some reasons to flip it around, but the point being that this is a positive control that can't really be recreated in humans. We don't have a big sciatic nerve we can put right back into the patient. So if we can create something in the lab that is equivalent to that sort of ideal positive control, then I think we're doing something good. So clearly cells help, and that has been sort of what has led on to creating this clinical trial, basically piggybacking off of a lot of Dr. Levy's work. We submitted a grant to the DoD that got funded, and now we're enrolling patients as of this year for this type of injury where they have a big segment nerve injury. We're hoping to enroll some patients this year. So if you see anyone in Ryder, even brachial plexus, we'll include those patients, but a lot of them is probably going to be peroneal and sciatic. So think of this Connor texted me recently about a patient. We have to connect on that. Usually it'll be, if it's a nerve injury and continuity, it ends up being 2-3 months out. If it's a transection, it's going to be sort of during that hospitalization, where the patients will get surgery and then get cells, their own Schwann cells implanted into the nerve repair. So we're recruiting hopefully 10 patients, only exclusion. There's several exclusion criteria and we could go over that, but if you see a nerve injury, then let me know. So we know Schwann cells work, but what are their disadvantages? Well, essentially they require a separate incision for harvesting the nerve. They must be autologous because there have been investigations using donor Schwann cells, but patients need to be immune suppressed. And then it does take about 2-3 weeks to generate these cells once you do the biopsy, and it requires specialized facility and techniques. Some institutions haven't been able to recreate it like the Miami Project or University of Miami does. So is there another option? And we're recently looking at out in Calgary, Raj Mehta is doing skin-derived Schwann cells. And here we've been looking at something else. But the reason that we choose Schwann cells, they're pro-regenerative, they facilitate recovery after injury, they de-differentiate and proliferate. Regenerating axons express adhesion molecules that promote Schwann cell alignment migration. There's bidirectional communication between the axon and the Schwann cell. But how does this communication occur? And it's believed that much of the communication is accomplished via these small vesicles known as exosomes. And so that's what we're now investigating, whether we can use exosomes in lieu of Schwann cells and achieve that same benefit, because exosomes don't have that immune response, and you can implant some exosome from a donor into someone else and not generate an immune response. So what are these? They're known as EVs, extracellular vesicles, or exosomes. In this particular case, we're talking about 50 to 100 nanometer diameter vesicles. They carry mRNA and microRNA, and many cells secrete them. Probably all cells do: oligodendrocytes, astrocytes, microglial cells, and Schwann cells. They're messenger particles that were originally described in cancer research, and at first they were thought to be waste carriers. And then it was found that they manipulate the local and distant microenvironments for cell survival and dissemination. So they're an important player in how cancer cells move around. They originate through a means described here, and there are commonalities between all exosomes. They have these transmembrane proteins, they have heat shock proteins, they have they're generated from these multivesicular bodies, and they have these multivesicular endosomal proteins. So the only reason that's important is that you'll see how they're generated in a second, and we just have to prove that these are exosomes because you can't really see them. They're so small. We have to have some characteristics that we can use to define them. They're actually been recently implicated in several disease models, including Charcot-Marie Tooth disease and Guillain-Barré syndrome. We see that exosomes play a role in the pathogenesis of these two diseases in particular. And I bring these up because these are Schwann cell mediated diseases. So we're now looking at how exosomes are studied in the context of Schwann cells. And probably, this research has only been going on for the last 15 years or so. And that's kind of when you start seeing these exosome publications come up. And more recently, since 2020, you're seeing kind of their explosion of these exosome publications. Dr. Dietrich just got an R01 looking at exosomes in TBI. So the NIH is also excited about this. So I think, I think we're excited about looking at this in the lab, and I'll show you some of our preliminary data. This is a study from the journal Glia looking at Schwann cell-derived exosomes and how they enhance peripheral nerve repair. They're generated from the supernatant of a Schwann cell culture, and then that's centrifuged down differentially, and then they take the little pellet, and then the Schwann cell exosomes specifically have these two markers, CD63 and P75, and that's shown in this paper that was published in actually 2013, and this is one of the highly cited papers for Schwann cell-derived exosomes, and they show enhanced recovery in vitro and vivo. This is a really nice review that was published in 2021, looking specifically at Schwann cell exosomes, goes over all these characteristics, and it shows that the regenerating Schwann cells versus the mature Schwann cells have different exosomes that actually tell the axons different things. And this has been shown in literature. And here was a cool one published in Diabetes in 2020, where they actually, it was in rat or mice, and they generated type 2 diabetes and peripheral neuropathy in these mice, and they gave they gave exosomes intravenously and showed that it helped reverse some of the changes in the peripheral nerves. So this then begs the question, I think, to us, what's the best way to give these exosomes? You know, there has also been literature looking at peripheral nerve injury, exosomes given intravenously, and they've shown that the exosomes actually will target the nerve site. And so I think that created this question to us, you know, what's the best delivery technique? We'd like to deliver them locally, and that's how we have been doing it. But intravenous delivery offers the ability to deliver them several times over the next few days. So sort of like, you know, that's our latest question. So for our research, our overall aim is to determine the ability of exosomes to enhance axonal growth. We want to look at in vivo and in vitro testing, and our hypothesis is that exosomes will be a more beneficial method of treating peripheral nerve injury than, you know, an empty conduit. So here are our groups, and we look at a rat sciatic nerve defect of 15 millimeters. We're looking at human Schwann cell-derived exosomes presently. In our next iteration of experiments, we'll look also at rat Schwann cell-derived exosomes. We first showed that they can be introduced into these conduits, and here is a scale bar down there showing 170 micrometers. And these are GFP labeled exosomes. So here are some of the outcome measures we looked at. The autonomy score was similar in all groups, which is just a sort of surrogate for neuropathic pain. This is a sensory calculation to see how, you know, how the animal is perceiving a filament placed on the paw, and that improved in all animals, no significant differences. Similar to this measure, no significant differences. And by the way, the groups are autographed here, Schwann cell loaded conduits and exosome loaded conduits. So I don't have the empty conduit group yet. That's going to be our negative control, and that will be coming out in the next few weeks or months. We did see a significant difference in the muscle weight between all groups. So we harvested the gastroc on the ipsilateral leg, and we showed that there was significant size difference between autograft, Schwann cell, and exosomes. So we may see some early results suggesting that exosomes aren't as robust as giving the cells themselves. But we haven't seen any differences right now on the electrophysiology, and we're still analyzing that. Emily's here with us, and she's been a big player and participant in doing all this data. So the next group to add is the empty conduit group, and that's going to be our negative control. So that should be coming out in the next few weeks or months. And this is sort of an image of the injury model that we're doing. And so here are our conclusions. They probably are less robust of an effect than Schwann cells themselves. But remember, we just gave exosome one time at the time of injury. Potentially, we could continue to give them maybe ultrasound guided injection or intravenously after the injury for the next several days over the course of a week. And so, like I said, the empty conduit group is coming out. And here's a thank you to everyone. We do have now an Instagram account, so you can stay up to date with all the latest news because the Ashis's Lab created an Instagram account and a webpage, so we're trying to keep up. And Emily, thank you so much for all the great work you're doing, and our medical students, including Joe, who's with us for the year. So thanks.
All right, I think I'm up next. Can you guys see my slides? Can't really hear anyone.
Yes, we can.
Okay, perfect. All right, good morning, everyone. I apologize for not being there in person. I'm up in Palm Beach Gardens for a clinic today. So, you know, I think obviously all the residents and fellows and faculty know me. But I know there's some industry sponsors. Again, I apologize for not being there, but you know, Greg Basil, one of the spine faculty here, and I'm going to be talking to you about integrating new technologies and approaches into your practice today. Here are my disclosures. So, you know, I'm going to start with the basic premise. And that premise is that the easiest thing to do as a surgeon is to not integrate new technologies. You could encapsulate that statement and say that inertia is powerful, but I think there's more to it than that. Obviously, we all spend many, many years learning how to do surgery, how to do spine surgery, brain surgery if you're a cranial neurosurgeon. And we learn certain methodologies, we learn approaches, we learn how to do surgery using certain tools. And so it's very hard to kind of change our ways. That's also partially due to the fact that I think new technology and techniques, equate to added risk plus added effort. Now, there's obviously some added benefit as well, and I'll talk about that in a minute. But and if there wasn't that benefit, we wouldn't do it at all. But what are some of those risks? One of the risks is that you haven't yet had enough experience in that technique or technology to employ it in the OR. And basically that you're not comfortable enough with it yet. Another is that the technology has unknown adverse effects or downstream impacts. In other words, if it's a new interbody, what's the fusion rate? And those risks can be mitigated depending on where you are in the adoption cycle, and I'm going to get into that a little bit later. And then I think finally, and this one can't be understated, that there's a significant effort required to become proficient in new techniques, and that can be very difficult to fit into your existing practice. And so, why bother at all then? The obvious answer is that, some innovations represent real advances in terms of, comparing them to the standard of care. Of course, not all innovations are going to end up in that category, but, what are some of the things the, new innovations or techniques can do for us? They can improve patient outcomes. They can improve workflow and efficiency, cost effectiveness, decrease physical exertion, fatigue, decrease radiation. And I think if you look at some of the technologies that pretty much probably every vendor in a room is showing today, they hit at least one of these checkboxes, or in many cases, multiple. Another thing is that patients are becoming more and more educated. Information is obviously very easily available, and patients are asking for some of these technologies. Now, I'm not suggesting that just because a patient asks for technology, we should use it. I'll tell you that the most common thing patients ask for in my clinic is a laser. I always ask the patient, I said, where do you want me to use the laser? And they don't really know. Obviously I'm not going to start using a laser, but if there's a technology that does have real value and patients are asking for it and want it, there's no reason that we shouldn't be doing those things. And I think finally, innovation and research are critical for advancement. And, I'm not just talking about personal career advancement, but I'm talking about, our field, spine surgery, neurosurgery as a whole. Obviously, certainly when you look at it from a personal standpoint in academia, staying stagnant, not adopting new techniques, technologies, not trying new things is not very good for your career. And if you look at how spine surgery has evolved, this is a great slide from one of my good friends, John Yoon, who shows the progression of MIS surgery, over the years via spine journal cover art. And you can imagine, and there's tubular retractors in this. There's screw-based retractors. You see the lateral approach represented here, and you can imagine that if we hadn't adopted some of these techniques, the surgery that we're practicing today would look very, very different than what we're actually doing. And so if you're sold on the fact that in some cases in technology that we believe in, it makes sense to and I say enter the market, I mean start adopting that technology. You can start using this theory, which is a guy by the name of Everett Rogers. He was a sociologist out of Ohio State University. And you guys are probably all familiar with this, called the diffusion of innovation theory. You might not have heard of the name of the theory, but you've definitely heard these categories of people in terms of innovators, early adopters, early majority, late majority, and laggards. And these check marks and question marks and X's I've put are a little bit arbitrary, and I'll explain what I mean by that. The innovators, we all know who those people are, right? Those are the people that are curious, they're willing to take risks. They don't necessarily need a lot of research. I put a check box next to them because in academia, you're more likely to see people innovating, and they're the people who don't necessarily have the research, but are going to build the research, right? And so, as an academic neurosurgeon, that's not necessarily a bad place to be. Obviously, and again, we're going to talk about evaluating and understanding the technology, assuming that you've done that. Early adopters, that's a question mark. I think, again, in academia, you're more likely to be an early adopter. But again, at that point, you have minimal scientific evidence. Early majority, the scientific evidence is building. And I think most people in this room would be comfortable being in this group of people. And, the benefits, of course, of being in, anywhere on the left, which is innovators, early adopters, and even early majority, these are a lot of people that are going to, can make a name off of these technologies and these approaches and be talking about these things on a national stage. And you can think about something like the lateral approach and Juan Uribe and understand how that can play out. Obviously, late majority, and laggards are, that's a category. I think certainly laggards that most of us don't want to be the last people accepting a technology that's pretty well established in the literature. But I think you have to understand the elements of this innovation diffusion, and there's really 5 basic elements that are discussed. The first is the innovation itself, and this is a little bit obvious. More disruptive technology that has the potential to change the field more obviously has a greater potential. Innovations that represent minor changes to the existing way of doing things, maybe less so. Adopters refers to the people that are using the technology, but people is actually probably the wrong term, because I think you need to understand that, surgeons were one component of this, but the hospital as a whole is another system. So the hospital may buy a technology without necessarily consulting with the surgeons. Obviously, that shouldn't necessarily happen, but it does. And there's a lot of reasons why that can happen. And obviously, you can, at a higher level, you can look at countries and states and things like that. Communication channels, how this information is being disseminated. Obviously, all the companies that are, investing in these technologies spend a lot of money in R&D. And so, when they have these products to bring them to market, they spend a good amount of time educating faculty and residents and things like that. So that happens pretty easily in our field, in the medical device field. And, again, in terms of time, that really depends on all of the above elements. So, if it's a very disruptive innovation, it really changes the field in a positive way, the time is going to be shorter. Minimal impact technology is going to take a longer time to disseminate, if at all. And then finally, the social system. And, you can think about social system, they list here mass media, surfactants, government mandates. You can think about the implementation of the EMR into hospital systems that happened under the Obama administration. So sometimes these things are beyond kind of our own personal interests and desires. And then finally, how that diffusion of innovation occurs, which is, obviously the knowledge builds first, people are persuaded or they're not, they either accept or reject the technology and they implement it. So we're going to talk now about the implementation, which is really the bulk of this talk. And so, I've created some basic steps here. This is obviously my take on it. There's obviously, a million ways that you could decide to break down this process, but I think this kind of distills it to its core. And so the first is to understand the technology and its core value proposition. And so for each of these steps, I'm going to show an example. So for this case, I'm going to talk about spinal robots, and I've actually included a graphic from one of our own, Jennifer Mao on the right, showing the technological evolution of the robot. And I'll talk about that in a second. But, what is the value proposition of the robot? And now there's a lot of literature on this. It's pretty well established: improved accuracy, decreased facet violations, decreased surgeon effort in terms of both physical and mental. This idea of rationing off your mental energy, not spending a lot of effort trying to put the screws in so you can spend more time on the deformity correction, for example, decreasing radiation exposure and potential time savings. And, this is the purpose of this is not to talk about robots or not. We can argue about whether or not it's time saving. It depends on your level of experience, but this is a value proposition of the robot itself. And then the technological foundation for robotics is extremely sound. And, you could see on this graphic on the right, if we really, and it's a little bit of a stretch, but if you take it back to its original technological foundation, you're going back all the way to the 1800s, but really, the mid 90s and forward. And it's basically foundational, technology is stereotactic navigation and computational science. So clear value proposition, clear technological foundation, and you see robotics disseminating, relatively commonly in our field right now. I think the next component is to understand, the economics behind a new technology. And, what I'm not suggesting is that anyone or everyone in this room try to become a financial analyst. Obviously, that's not, that's not what we train for, and it's not necessarily the interest of many of us in this room. But I do think we need to have at least a basic understanding and ask some important questions about this technology before we dedicate that time and effort towards learning it. And, the first, of course, is what does the technology cost? And, obviously, early on technologies are generally quite a bit more expensive than they will be down the line. So you need to take both a short and long-term view on this, but I think you should have a general idea of at least an overall cost. If it's a large piece of equipment, what does that piece of equipment cost? Or if it's per case cost, what is the cost per case, and what is your reimbursement for that case? And is it even financially viable? Because even if you don't ask these questions, when you present this to the hospital to try to bring the technology, this is what they're going to ask you. The next is, how often will I or surgeons in my practice use it? You're going to be presented with technology pretty much every day. And if you try to integrate every piece of technology that's presented to you, you're going to have a pile of crap just sitting in a corner in the OR, most of which you're never going to use. So trying to understand, its utility to you and the frequency that you plan to use it, I think is very, very important. How will it be paid for? And again, none of us as surgeons are going to be, most of us as surgeons are not going to be directly paying for this, but the hospital will be, or the surgery center, depending on where you work. But there's obviously lots of purchase options, and a lot of these are obviously there's a lot of cross-selling opportunity with many of these technologies. So our industry partners always want to help us get this technology in OR. So there's a lot of ways that you think about rebate programs where your usage of certain instrumentation could go towards buying the actual equipment piece. So I think just understanding that in a basic way is very important. Is there a real systemic need, desire for the product? And we talked about this, understanding its impetus for creation. And then the final one I think is also super important is like, what are you going to do with your existing purchase technology? If you've already bought a navigation system and that navigation system has a 20-year life, how is that going to fit in with robotics? And the answer is you're probably going to use both of them, but understanding that and understanding your sunk costs and your new potential costs, I think is really important. So this is an example of this, and this is obviously a higher level of detail that I'm expecting that you guys go into, but this is a nice paper. It was written out of India, actually, talking about augmented reality and virtual reality in the OR and in terms of the spinal OR. And they go through, and I just put up this quote here. It's a long quote. I'm not going to read the whole thing to you, but they go through kind of each component of what I talked about. So first they talk about the value proposition in terms of operative procedure, infection rates, revision rates. They talk about the total market size, and they talk about the early experimental results and the fact that this is quite scalable, and they conclude that this is basically an attractive technology moving forward. So I think that's the kind of analysis on a kind of a more simplistic level that I think all of us should be doing. I think the next step obviously is very, very important, which is to understand the critical shortcomings of the technology and technique. So again, if we go back to that Rogers chart, understanding where we are in the adoption curve, early on, your literature search is going to be very minimal. And so you're going to have to understand that there are going to be a lot of gaps in terms of your understanding of the shortcomings. And I always say this, and I think it's important that you have to be wary of the early adopters who take an overly optimistic or enthusiastic approach, right? Because, the literature is building, and I think, it's okay to like an idea, but when the literature is not there, you have to be very, very cautious. And so my example here for me was spinal endoscopy. Obviously, that's something I became interested in. And, fortunately for me, that technology has been around quite some time. It's not really a new thing. And so the literature is there. And when you look at the shortcomings of that technology, it's not generally good for high-grade disc migrations. It's not good for large central disc herniations, at least not early on. And there's a significant learning curve, about 40 cases. So once you understand that going into it, you can adapt your approach to this technology. I think the next part obviously is begin to develop hands-on experience. There's tons and tons of industry-sponsored courses, but many of them are often short with time on the cadaver. So, I'm going to advise that you pick your courses wisely. I'm going to talk a little bit about that in a second. And obviously, I think cadaveric labs are best. That's the closest thing you can get to true surgery. But it's difficult. You often have to travel to get to these. They take a lot of time. And I think model-based learning is becoming a more and more realistic way of training. This is a particular model that I use to learn spinal endoscopy. And it's got a spine in it and nerve roots and everything. And it's very, very effective for being able to target Kaman's triangle. And now I know there's tons of these highly realistic models being marketed for cranial surgery as well. I think UPR is one of them that makes them. And so I think more and more this is going to play a big part. And, we studied this. This was studying using a synthetic model in the lab to learn endoscopic approaches to the spine. And we found that our trainees were very pleased with the simulated models, and actually found them just as effective as the cadaveric model in terms of the approach. The next component as you go on and again are starting to learn this technology is understanding where on the time investment spectrum the technology lies. And so, Dr. Levy talked about artificial discs today. And I think for someone with an ACDF who already does lots of ACDFs, learning artificial discs doesn't really represent a significant investment of time, right? You could probably have, 1 hour seminar where you walk through the specific instruments and, the recommended technique, and you could go forward and do that procedure with very little difficulty. Whereas if you go to endoscopic surgery, that requires a significantly higher investment of time and effort. And you just have to understand that this is, some papers on the learning curve of endoscopic spine surgery showing in this one surgeon that over 3 different 8-month periods, his rate of reoperation dropped to 0 basically. But, in the first period, out of 19 patients, he had 6 reops. In the second, he had 1. And so clearly a significant learning curve. This is another paper showing 2 groups of people, one who had experience with endoscopic surgery and the other who don't. Group A are the ones who don't have much experience. You can see their operative times, intraoperative bleeding, and postoperative hospital stay are much longer than the other group. But again, you see that, after about 60 cases, they're equivalent in terms of the reoperation rate. So again, just understanding this, I think, is obviously very critical. In terms of a practical note on course selection, all of us, I think, jump to go to any cadaveric course, which is great. But I've been to plenty of courses where there's 50 people there and each person might get 20 minutes on a cadaver. Those are relatively low yield. They're good primarily to just be introduced to a technology, not how to learn how to use it. And obviously, I think the key here for all these cadaveric sessions is to come early and to stay late. Most people want to come in, these are people in practice, they want to come in and come out, whatever. If it's a TLIF they're practicing, do a TLIF and leave. We have some fellows who are great examples of this. I think all our fellows have spent a ton of time on the cadavers when they go to these labs, but Sasha Vaziri is particularly a champion when it comes to these cadaveric courses, and he's there early, and I always see him, picking apart the cadavers to the end. But that's how you really maximize your experience and your learning potential. I think the next thing is to pick a good first case and build in extra time. And it's kind of obvious, right? Pick the perfect patient for the case. But again, when I think about financial modeling, we always say, okay, you guys have a likely scenario, a stress scenario, which is a worst case scenario, and then a best case scenario. And I think you should always plan for the worst case in terms of the time it's going to take you to do a surgery. So, this is on the left, I show, I think, what would be probably a good case for your first artificial disc case, which, a nice soft disc herniation. But as you're starting to do these new techniques, I wouldn't put necessarily pack your day. And, for example, if I'm doing an endoscopic interlaminar, I'm going to give myself a long window to do that case so I don't feel the stress of time on top of the stress of doing a new, potentially difficult technique. And so, I give examples of, I show you the sort of cervical artificial disc is a good example. Endoscopic decompression would be like a foraminal disc, not a large migrated fragment. And for a robot, like a multi-level perk screw instead of 1-level open fusion. I think my first or second case of the robot was like a 1-level open fusion, and it wasn't a great, first or second case of the robot for reasons that we could talk about in a different conversation. And then obviously, I think you have to understand that things may not go as planned and have a backup. So you should not be too wed to the technology that you ignore potential issues as they arise. You have to be willing to convert to a more comfortable approach or technique if needed. And I think the last one is something that I think about a lot, which is consenting the patient appropriately if needed. And so if I'm doing something that I'm not sure, for example, if it's a 5-1 transforaminal endoscopic, which is a difficult endoscopic case, that a lot of people don't do 5-1 transforaminally because of the challenges of the iliac crest, I'm going to tell the patient that I'm not 100% sure whether we're going to be able to get it endoscopic. And if we need to, we'll do a tube. And that way, if you get to that point in the surgery where the endoscopic approach isn't working, you're not in a bind where you haven't already spoken to the patient about this. And I think, it does take a little bit of mental pressure off of you as well in the case. And I think finally, you just begin to develop your own understanding as you do this of where this technology or technique fits in your practice. You have to be scientific in your examination of your own experience. So actually study this. Don't give up just because your early experience was challenging. I think with all of these new techniques and technologies, there's going to be times when you get frustrated with it. It's going to be harder at first than what you're used to doing. But you have to try to understand where those challenges lie and address them if you really think this is meaningful for you. And then finally, obviously, document outcomes, complications, and adapt accordingly. So that's it for me. Thank you.
Okay. So I see we lost a couple people, probably obviously to some of their other duties that they had to do today, off to the OR and to clinic. And we've had a lot of great talks today. My name is Matthew Cummock. I'm one of the spine fellows here at University of Miami. And I'll be staying on as faculty as well. So I wanted to talk a little bit this morning about something that I'm passionate about, and I think is very interesting, is augmented reality and kind of where we see things where they are now and some future directions. No disclosures. And I just want to thank everybody that's participated with the conference today. We have a lot of great vendors out front, so please go out and check out their booths. So just to start out in a real basic sense, just some definitions: augmented reality versus virtual reality. AR is the overlay of data on top of reality. We know this through some of the games we've seen on our phones, and there's a photo of Google Glass there back in 2012. And versus VR, virtual reality, which is fully immersive. And we know that through Facebook Meta, a photo there of Mr. Zuckerberg on the right. And really, this has kind of captivated our imagination, at least for me personally, over many years through pop culture. And we've seen it in the movies through Top Gun in 1986 and in Terminator. And then more recently, we've seen it innovate and develop into movies like Minority Report and Iron Man, where we've seen it really kind of explode and how it's being adapted and utilized throughout the science fiction. And most recently, you can see that with manual manipulation of images and artificial intelligence. So AR current applications, we're using it throughout not just healthcare, but retail, industrial applications, design. The military's using it, customer experience. And then through some of my research here, I thought it was pretty cool that we're using it. NASA's using it, specifically the HoloLens, to build spacecraft faster. They've gotten rid of their manuals and they're using these Microsoft HoloLens to guide them through building spaceships, essentially. So AR in spine surgery, there's kind of a long storied past about how we got to where we are. But today I really want to focus on really about 2018 to about now. So really the past 5 years, where we've seen a lot of FDA approvals and explosion and growth within this space, and finally adoption into the OR. So there's a lot of different, a few different displays of augmented reality in spine surgery, but I want to focus just for simplicity's sake on these 3 types. We'll start at the bottom, the HMD, that's a head-mounted display, and I'll end up showing you a couple different examples of that, and that's actually something that we use here at the University of Miami as well. And then there's a microscope heads, basically a heads-up display where the image is superimposed through what we see through the microscope, and you can see that on some of the Brain Lab equipment. And then something called ARSN, which is augmented reality and surgical navigation. And that's what you see there on the images on the right, which is something that's done through a hybrid OR with biplanar fluoroscopy. And that's approved over in Europe, but not here. Okay. So really, we've looked at the 3 types of devices that we can use. Now there's the basic function of these augmented reality comes down to, from my research, really 3 types as well. And a lot of these are improved visualization devices that connect to expensive hubs and are able to project what we would see on a different screen over through that head-mounted display or some other type of visual apparatus. And then there's true navigation devices that only require putting imaging into the device, either through an intraop CT or preoperative CT, and then it allows you to navigate everything itself, and that it allows us to circumvent basically big, expensive navigation machines. And then there's the last thing that, which I think is going to be part of the future, is these devices that incorporate artificial intelligence, and I'm going to show you one of those devices here this morning. So again, here's some of the devices that utilize augmented reality, but are just more simple visualization devices, projecting what we had on a different screen onto something that we can see through, utilizing either something like this on the bottom right here, the Magic Leap, as well as the Microsoft HoloLens. And then there's only a few devices that are really real surgical navigation units. And we investigated this with some. I was involved in a project up in the Northeast that utilized this Magic Leap head unit, and you can see it here in this small photo in A. But it also had a lot of other big expensive devices with it to produce the images that we see up here. And that included a stealth station as well as surgical theater. So we were able to get these beautiful images and show that it worked very well, but to incorporate all this technology would be extremely expensive. So talking about the heads-up display, that is a true navigation device. There's a device, it was the first FDA approved device to be used here. It's called the Augmetics X Vision. And again, it was approved in 2019 and recently approved for cervical and pelvis use. And this is a head mounted display that incorporates all the navigation within it. And it does a couple different things, which I'll show you some more specifics on in a little bit. But it does incorporate 2D scan data, which you can see here, our typical axial and sagittal views that we're used to, as well as reconstructing a 3D model that we can see here. And you can see this, this computer interface in the background where everybody can follow along, as well as the two displays that are head mounted here. And we'll have some more info on that later. One of the new AI devices is this this device from Surgalign called the Holo Portal. It was approved in 2002, so recently by the FDA, and it includes this screen that overlies the body, and through that screen, you're able to visualize the 3D rendering that's done underneath, and you can see it very quickly there. A lot of these projections here, and it uses augmented reality and artificial intelligence to pre-plan where the screws and ideal trajectories of those screws would be through the anatomy. So I think this is going to be very powerful as far as this technology or as far as incorporating this idea of artificial intelligence and being able to tell us exactly where the best screws would be based off the anatomy. This system is a little bit cumbersome because it is a screen that overlies the cadaver, of the patient. And it can obviously get in the way of when we're trying to place some of our instrumentation. So here's a list of full FDA approvals, and there's actually a lot of technology on this list that before putting together this talk, I had not even heard of, but we can see that the space is rapidly growing. And when going through the past conferences over the past year, specifically at the North American Spine Society, the NASS meeting, you could see a lot of these players out there having people trial their different types of platforms. So I think the future is bright and we're going to see a lot of different technology come through here. So really, I think one simple question is, what's the point? What's the point of augmented reality? What problem are we trying to solve? Many people argue, we already have great navigation. I'll raise the question. I'm sure many of the different surgeons here in the room can attest to this. Well, do we? Is the navigation good enough? It's kind of a long stretch, but when looking back at other successful technology, the iPhone was successful because it combined two existing technologies, specifically the mobile phone and a mobile music player. So what's the point with AR? What are we combining? Is there technology that we're actually combining with augmented reality? And I would argue that it combines navigation, better ergonomics, and it is much more cost efficient. So problems with current navigation systems, I think this slide sums up a lot of what we see in the OR, is as a surgeon is placing, in this case, instrumentation, the attention is shifted away from the operative field, which can be detrimental in a lot of different ways, especially if you don't recognize that perhaps your starting points are off, or perhaps the registration of the imaging is off as well. As we can also see here that there can be line of sight interference from the camera itself as people get in the way of the camera eyes seeing and following whatever instruments we're utilizing here. This whole tower and these devices can be extremely expensive, over $1 million. And certainly there is a learning curve when learning with all of these technologies. And just want to talk a little bit or just mention that, navigation would be used by a lot of different surgeons if they had access. Here's an older article back from 2013 in World Neurosurgery by our colleague, Dr. Hartle. And he submitted a survey out to the AO spine surgeons, of which there were 677 responses. Of the 508 surveys sent out in North America, only 60 surveys came back. So, admittedly, this is not wholly encompassing of all the views of different of all of our spine colleagues. However, I do think it provided some valuable information, specifically showing that obviously we do a significant proportion of spine fusions, about 50% every year, that are over or at least over 100 spine fusions a year. About 50% of people are doing that, and that we're utilizing some minimally invasive technology, especially more here in North America and Europe, and that number is on the rise. And then within our hospitals, of those 60 surgeons from North America, over 50%, about 70% said they had some sort of computer-assisted navigation system. But while it was readily available, the routine use, and I'll define that as, saying in select cases, and then also, yes, utilizing it routinely, was only in about half of the surgeons here in North America. But for the people that are doing more spine fusions, you can see that they used more of the computer assisted navigations. So the point of this saying, I think, as more people, as you're doing more fusions in America, and if not the world, we find more benefit with computer assisted navigation. And therefore, I think we can find benefit of this technology as well, augmented reality. And that's generally what they found here in this article, that most people found or saw benefit in computer assisted surgery. And some of the difficult reasons, or the reasons why they weren't using it, is because they weren't able to get it because the technology itself was very expensive, or they weren't able to get the right training for it. So a little bit about the technology that we utilize here, the augmetic system. Some of the residents know this well. It's founded in 2014, and I'll just let this play as we're talking. There we go. So again, it's a head-mounted display. It allows you to see through these two retina-based displays here. And again, giving us 2D vision up top, our typical navigation that we're used to, both our axial and sagittal visions, as well as the 3D visualization down below. And these are images that you can move around or turn on and off as need be, while you're basically to whatever you prefer. Admittedly, the 3D rendering never looks as good as it does here. Clearly, we're doing spine surgery for a reason. So usually there's a lot of pathology there that makes the 3D rendering a little bit more complicated. There's redundant tracking by multiple headsets. And so the fidelity seems very high as we're placing our instrumentation. Okay. And again, summarizing some of those things. I think very importantly is look at the surgeon's faces here. They're looking down within the surgical field. They don't have to turn their heads looking at a screen and into a different place. Okay. Well, none of this would matter if it wasn't accurate. And there's been a lot of different studies as these new devices have come out, specifically since 2018, about looking at the different technology and trying to determine its accuracy. Here's one that came out here from our colleagues at the University of Miami. Dr. Yurikov and Dr. Levy, they looked at one of these early devices with the Microsoft HoloLens to see about the accuracy in a cadaver model. And unfortunately, they only found that it was accurate in about 63% of the time. Here are some of the highlighted screws with a very significant medial breach. And a lot of that was due to the difference in technology, the lack of active tracking that is done during this procedure. So I think we've come a long way since this time with a lot of the technology. Specifically within the augmetics unit, there's been a lot of studies that have been put out showing its accuracy first in cadavers, and then ultimately in 2020, this was the first in man paper with 100% accuracy, and then just continuing on with utilization and documentation of its accuracy in both open surgery and through percutaneous fusions. And another study, the most recent one in September 2022, showed that only 3 screws out of 606 pedicle screws, only 3 screws had to be replaced intraoperatively, and there were no revisions. And so, in total, with this specific device, through 1,401 screws, they've been able to demonstrate extremely high accuracy and consistent accuracy throughout the years, at least over 96%. So the second question, we can't talk about accuracy if we don't mention precision, and precision is what is required just to get FDA approval, specifically two things: linear tip deviation and angular trajectory deviation. And both of those things have to be less than 3. That's the magic number that the FDA wants to see. And that's less than 3 millimeters of linear deviation and less than 3 degrees of angular deviation. And we can see both of those things were achieved. So yes, it is precise. And some more studies that they put out. And I think if we can have one big takeaway from these slides, it's really these two pictures as far as utilizing both these technologies in my training, where again, looking at the line of sight deviation, which again is fixed with these devices, allowing you to look straight down, assisting your co-surgeon, and also having an extra set of eyes to make sure that instrumentation goes exactly where you want it to go. So we're not just utilizing this to put in screws. We're utilizing augmented reality to take out tumors, and it's been found to be very effective. So how do we prevent some of the issues that's happened with augmented reality in the past? We all recognize this device. Hopefully, this was declared one of the best inventions of the year in 2012. And then a short 3 years later, a lot of different articles came out about why it failed, why it never took off. And a lot of it, I think, was, at least in the summary of these articles, was how it was rolled out and how it was given to people for them to determine its use and not actually done beforehand. So they rolled it out too quickly. This year, Apple is actually planning to release in a few months their own set of augmented reality glasses. Or goggles. They don't know exactly what it's going to look like. But again, I think there's a lot of new players, obviously some pretty big players that are investing into this technology. And hopefully we can utilize those things that we see in other industries and apply them to the medical industry as well. So overall limitations, there can be reference frame. So limitations of augmented reality, essentially, whatever we see with navigation, some of those issues can be applied to our limitations that we see in augmented reality as well, such as reference frame manipulation. There can be some discomfort with the headset. And again, that's personal depending on what type of headset you're using. Some people find that there's too much information going through the headsets, and that can be changed and personalized through some of these programs. However, the benefits that I see with augmented reality is it really is vendor agnostic. So you can put in any type of screw or any type of inner body with that device. Again, it minimizes attention shift, which is very important. These devices are much, much less expensive to get into an OR versus some of the other navigation systems that require a lot of buy-in. And I do think after utilizing this device here over the past year at the University of Miami, it's very helpful in visualizing complex pathology, specifically complex deformity and degeneration cases. And then I'll point out quickly that I do think it helps to flatten the learning curve as well. Okay. Future developments of augmented reality. I think we're going to see more integration of artificial intelligence, which is going to allow for pre-planning of screws. I think, as you can see here on this video, this is Oliver and myself at one of the conferences. He's a co-fellow of mine, and we're playing with one of the systems from a different company called Metavis, which is allowing us to manipulate that spine model in 3D in midair. So again, having that hand manipulation, I think we're going to see that on some future devices. Being able to register to a pre-op CT, so not needing the intra-op device anymore, I think is going to be helpful. Smaller goggles, obviously the heads-up display that I showed you earlier is not small, and some people can find it uncomfortable. And then advancing some of the navigation to some of these advanced maneuvers, such as placing inner bodies and when doing osteotomies and MRI integration instead of just using a CT. So here at the University of Miami, we recently did our 50th case. And here's Dr. Wang leading that charge. And so again, I think where the system really excels is using navigation and augmented reality to help with complex deformity cases. How do we get from this picture here on the left to this one here on the right as safely as possible, not just obviously for the patient, but for the surgical staff as well. And in this particular case, we utilized fluoroscopy, and there were a lot of pictures. So we took a lot of pictures in this this case, and specifically 471 total exposures of X-ray with a cumulative fluoro time of about 6 minutes. And again, that's not just for the patients themselves, but that's for the surgeons as we are standing right next to that machine, putting each one of these screws in. So is there a way we can do this better? I think the answer is yes. I think navigation helps do these complex cases better, and specifically augmented reality, because it incorporates not just the navigation, but also that 3D view. So as you're placing the screws, you're able to line them up better in such a way where you're able to think about the rod that's going to be placed later on down the line, and to line up the screw heads better to minimize or optimize the placement of that rod. And here we were able to show, at least in this case here, that they did three CT spins to place all the instrumentation. The other point is, again, this flattens the learning curve. We've had professors of neurosurgery here showing of the junior neurosurgery residents how to place. Dr. Yurikov showing one of our junior residents how to place a heads-up display of augmetics. Everything's looking good. Thumbs up. So really, this is something that is able to be done and learned pretty quickly, especially for people that have grown up playing video games. And I would argue potentially for people that were not trained traditionally with some form of navigation through their training. I think they're able to incorporate it better and easier because they don't have to look away at a screen. Okay, they can look directly down at the surgical site. So some of the future studies that we're going to start to put out is looking at this data. We're able to look at how quickly we're able to insert each screw, and we can really, you could track it down or to each fellow or resident as they're placing those screws. And so we can see if it truly does help us put in screws. Obviously, we want them to be safe and accurately placed, but we want them to be efficient as well. Thank you. Here's a photo from our recent spine section meeting with a lot of the University of Miami neurosurgical staff and prior fellows and residents. So we had a great time. Any questions?
I have a question.
Yes. Sure. Yeah, it's coming. They're looking to, all these companies are starting to make partnerships. So the big companies are starting to partner with some of the smaller ones, the ones that we saw that list of FDA approvals. So I think, yes, the answer is you'll start to see the fruits of those partnerships start to come out in the next couple of years. And the companies that have very strong robotic presence already, you'll start to see augmented reality be incorporated into that or utilized at some point. And I don't think it's going to be 100% perfect when they first roll it out. I think it will take some time to get it better, just like we saw over the last 40 years of augmented reality in movies. It's going to keep getting better and better and better. But ultimately, I think being able to not look away at a screen that can be across the room or very difficult to see, but again, keep your eyes on the patient is going to be the most important thing. Cool.
Well, thank you.
Thank you, everybody.